got no muscles right now, it's all bones right now. You want to be able to grab the side muscles of your patient. I usually like to lift a little on the right and left side. And that's gonna give me this is what I want to do. I have a diamond shape in between my thumb area of my fourth generation. So the tip of my two thumbs, this is gonna be going to my spinous process for direct PA, fourth generation. So again, AP stance, where is your head gonna be? Directly over that segment. If I have a runny nose, that should definitely drop on my C2 area if I'm doing C2 CPA on my patient, okay? Few things that you're gonna be doing. You think this is gonna be more convenient for you. You're gonna be hunching and shrugging your shoulder. That's not a good technique generation for your patient. So I would highly encourage you, just really drop your shoulder back and relax, and then this is your PA force on your patient. So lift, and then this is your C2, CPA, directly down, just pushing it down. If you're off in that segment, you're gonna do your rotational segment. That's not what you want to be able to facilitate on your patient. Going back to our differential diagnosis lecture, well, why would you do CPA over UPA? Think about first the anatomy of what we're pushing.
For extension.
So your CPA is actually for your extension limitation when you think about it as one, or bilateral symptoms. Think about right and left side symptoms of your patient. Patient with headaches affecting both sides, what are those? Migraine and tension headaches is going to be one of your testing for your patient's upper cervical spine. What UPA itself is going to be good for what headache? Seborrheic headaches, because it's only one-sided. But think about your facet hypermobility as well. On your patient, if you have some facet dysfunction or hypermobility or one-sided symptoms, think about your radiculopathy as well. Predict, and then pretty much one-sided neck pain. So what do you think is going to matter most? Maybe if you have some rotation, hypermobility as well, because you're just pushing that direction, you can do them right and left side. So general hypermobility. And then for your CPA, bilateral symptoms, think about your seborrheic headaches, any neck pain that occurs on both sides or condition, and then maybe limitation in your extension. Or just general hypermobility as well. Think about your OA, affecting just general stiffness, yeah.
Isn't CPA better for tension and migraine, not cervical headache?
Oh, sorry, yes. And migraine, both sides. So we did the C2 UPA, just going down directly to the table. Now we're gonna try to perform your OA joint or AO joint. You're gonna do your 8 fingers rule. So what I wanna do here, on the suboccipital area of my patient, have your mastoid processes. So where your ring finger is gonna drop, inferior to that mastoid process is gonna be your transverse process of your what level? C1. So I'm right there. So I'm just doing that force. But I put in the pressure direction there, you're gonna have to go on the ipsilateral eye of your patient because it's way deeper. If I'm doing my assessment on this as a UPA, I'm gonna drop forward into my patient, and your force generation kind of already in. So your direction is angled, almost 45 degrees towards the patient's eye. You guys appreciate that because it's gonna be a lot more deeper for your AO joint. So just 8 fingers roll. Distal to my index, my ring finger is gonna be your force generation for your UPA, like your AO joint. When you're doing your UPA on your C2, all you have to do is from that transverse process, you just drop down. I wanna move my C2 segment against my C3 So the same thing, grab the soft tissue, and I'm just doing a direct CPA on my C2. Directly down toward the floor, it's my force. UPA and C2, I want to move them against my C3 segment. So again, OA, 8 fingers rule. Distal to my ring finger is UPA on my C1, transverse process. If I want to move my C2 against my C3, drop down below the T1 transverse process, directly down. How many fingers of palm length again, going sideways? I found it in half of my patients, so I'm gonna wanna see his, and then match that with mine, and I have to drop down to my C2 and 3. If I wanna do my C2 on 1, I wanna be able to isolate it in slight rotation. So rotate to the right. I'm moving my C2 against C1 right now. The force generation is gonna be in the patient's mouth. So this way. Okay, so again, a atlanto-occipital towards the eye, FC. C2 on 3, directly down. Rotate 30 degrees to the right side. C2 on 1 is going to be towards the patient's mouth. So let me do this on a patient. Who's my next patient? No, thank you.